Good afternoon, good morning, good evening, wherever you are on this earth of ours. Welcome to a wonderful plenary session, this second day of the African Forum for Research and Education in Health annual symposium. It's the 4th annual symposium that AFREhealth is having. We have a wonderful team this afternoon talking to us about enhancing IPE interventions to improve patient outcomes and health security. My name is Judy Khanyola. I'm the chair for the Center for Nursing and Midwifery at the University of Global Health Equity in Rwanda. And I also double up as the secretary of AFREhealth. I'm very pleased to welcome you and invite you here this afternoon. A quick housekeeping sessions, and then I'll hand over to my co-moderator, Dr. Quentin Eichbaum, to introduce himself and set us rolling. Your microphones are off, and we request that you switch off your videos just in the interest of bandwidth. The moderators, myself, I will turn on my video to indicate to the speaker that they have 1 minute or 3 minutes left to wrap up. Each presenter will then go ahead to present. We encourage you to ask your questions using the Q&A chat box that you can see at the bottom of your screen, and we will man this chat box and answer your questions as they come along. Sorry, the Q&A box. We also ask that you use the chat box for interactions. You can greet one another, speak with one another as the session is going on, so that you get to know each other better. So without further ado, I hand over to Dr. Quentin Eichbaum to take it away. Over to you, Quentin.
Thank you, Judy. I'm Quentin Eichbaum. I'm the co-chair of the AFREhealth CUGH working group. I'm on the CUGH board. I was actually born and raised in Africa, in Namibia and South Africa. I tell people my soul is still in Africa, my body's in America. But I was educated and spent many years at Harvard Medical School, but I'm now a professor of pathology, immunology, microbiology, and also professor of medical education at Vanderbilt. University Medical School. Start off by introducing Petra Brysiewicz. She is a full professor of nursing and public health at the University of KwaZulu-Natal, and also professor in the Division of Emergency Medicine and the Department of Surgery and Health Sciences at the University of Cape Town. I'm a PI on the drill program at the College of Health Sciences in KwaZulu-Natal. Done lots of work in interprofessional mentoring and leadership, and is editor-in-chief of the International Emergency Nursing Journal, and as well the associate editor of many other journals. So welcome, Petra. We met many years ago at one of the AFREhealth meetings, and I'm good to see you here. So I will hand over to you now.
Thank you very much. Thank you for the opportunity to present today. So WHO highlights the push to increase the global nursing workforce, and nurses and midwives are said to make up nearly half the healthcare workforce. And WHO had estimated that by 2020, there would be a shortage of nearly 9 million nurses. As the world faces this growing shortage, there are also ambitious efforts to achieve the goal of universal coverage, health coverage for all by 2030. And in order to even think about making this happen, nurses need to be on the front line. Despite the nurses' contribution being really central to all of this, the value of nurses and nursing and the nature of their contribution is often poorly understood and undervalued. Influential theorists and nurse leaders agree that the nursing profession has difficulty in making nursing work visible to decision makers outside of the profession. And it's said that nurses operate often under the radar. So the COVID-19 globe, and this was also the case for nursing education. An international survey indicated that 73% of nurses associations reported that their undergraduate nursing education had been disrupted. There has been, however, increased interest in nursing education and the recognition of the profession due to this pandemic, and more than a 30% increase in the number of applicants to nursing training programs internationally. So we need to have a look at nursing education challenges and solutions for Africa, and particularly sub-Saharan Africa, according to this review. And what they found was that the challenges and solutions in nursing education are really common within a number of countries. There has been massive investment by various development partners in a variety of countries, and this has really resulted in positive developments for nursing education in sub-Saharan Africa. Strategic leadership, networking, partnership to share the sort of expertise and the best practices that have been learned is really critical. We need reforms to increase the capacity of the educators and the mentors. We need to improve the responsiveness of the curriculum and to ensure that we have transformative teaching strategies. We need strong regulatory frameworks and also the availability of necessary infrastructure and resources. So we know that the world is changing and that we are facing different sort of obstacles to what we were before. And we really need to look at our education and ask if it is really responsive to these changes. We have new types of students who now require new ways of teaching. And we really need to look at how we are teaching our nursing students and make sure that we are taking cognizance of this. If you look at the 10 skills you need for the fourth industrial revolution, it's really interesting to see how, creativity, problem solving, emotional intelligence, complex problem solving and critical thinking are essential skills. And we need to really look at our curriculum and ensure that we are making use of this. I think it's important to also consider the role of artificial intelligence and its application in real life clinical practice. This is a particular area that I'm interested in at the moment. And if you look at the research on this, you will see that it's still in the early sort of stages, and most of it's been done in the developed world. So more research is really needed to assess the benefits and challenges associated with these clinical AI applications. And we need to ensure that the rigorous sort of research methodology is being used. We have robots in healthcare already. This is a robot nurse who is delivering medical documents in a hospital in Bangkok. And it's been said that 800 million workers worldwide will be replaced by robots by the year 2030. So we really need to ask ourselves, how can human nurses remain relevant as practitioners of nursing? So I think there's a number of things that we need to be doing. We need to reframe our nursing education and ensure that it incorporates technology and machine learning. We need to increase the focus in nursing research that investigates the effects of this technology on the profession and look at ways to adopt this technology in our nursing practice. So nurses are amazing innovators. Here's just an example of an inflatable incubator, that decreased the number of premature child deaths. We've seen during the pandemic just how innovative nurses have been. This is one of my favorite. It's called the Hand of God. This was developed by Brazil nurses who used it as an idea to comfort ventilated COVID-19 patients. We also need to be thinking around climate change, and this Lancet paper really talks to the fact that we need to invest in climate change and public health research. We need to scale up financing for climate resilient health systems, and nursing really can play an integral part here too. I am very involved in emergency care, and last year we had a climate change workshop at one of our conferences. And these were just some of the points that came through really from our conference workshop. That education is a necessary driver of climate action. And we need to really look at the development of curricula at all levels of health professional education and continuing medical education. And this can either be as a standalone or integrated into existing programs. Health professionals, health researchers, and health advocates all need to be empowered and invited to really be part of the engagement as key stakeholders in this whole process. Climate change and health represents a new landscape for global health collaboration. So just to take you through a few sort of initiatives that we have undertaken in order to try to address some of these issues. So emergency nursing skills are often very scanty in many African countries. And in Tanzania, one of the ways to address this was to develop a short course. And this was developed by in-country clinical nurse trainers. And they were the ones that then have been teaching the course since 2011. This course was developed as a combination of the local knowledge through a formal mentorship program and by using international expert nursing support. And we did this to ensure that there would be sustainability and buy-in from the country. And this short course has been running for almost 10 years and has been accredited by the country Ministry of Health and by the higher education institution in the country as well. This is just to show you the nurses who were involved in developing the course and running the course, and also just to highlight the innovative and resilience of the nurses involved. You don't need fancy equipment to be able to make a short course work. We also identified the need to develop an African emergency nursing curriculum in order to help to harmonize the standard of emergency nursing practice and theory across Africa. And what then happens is this is then able to be used as a tool by countries in developing either formal programs or short courses. Through all this work, it also became apparent in some of the countries that there was a need to strengthen emergency care educational activities for nurses, and especially for nurses new to the emergency department. So a emergency nurses induction booklet was developed, and this again was developed through collaboration with in-country experts, other experts from Africa, as well as resources available from the WHO. And this induction booklet has now been used in a number of countries. When you have such specialty programs being developed in nursing in these different countries, it is important to think about how you're going to be able to provide support to these experts. And we also know that nurses in low resource environments often have difficulty establishing and maintaining contact with their colleagues, often due to geographical location and remoteness, due to professional isolation, or in fact, just due to the fact that there are limited specialty nurses available in their country. And one of the ways that has been found to be very useful is around, various mentorship initiatives. So we developed an emergency nurses mentorship project, and this was just the pilot with the mentors and the mentees. The mentees are on the left-hand side of the screen. And just to say that through these 4 mentees that were very successful, 2 of them are currently doing their PhD. I think that in looking back at initiatives that have been successful in nursing in Africa over the years, I think that we really need to recognize the importance that nurse champions play. And these are usually, sort of excellent practitioners who are passionate about improving the quality of care. And they embrace a project and enthusiastically promote it, encouraging the involvement of their peers. These are usually change agents who function at various levels as educators, mentors, leaders, and I think are really instrumental in helping to push the nursing profession forward in a variety of arenas. I want to touch a little bit on a collaboration that I'm currently involved in with 2 nursing schools, one in South Africa and one in the United States. And this is really around improving the curriculum regarding the utilization of clinical data. And in this collaboration, we have also, besides nursing, we have involved trauma surgery. So the trauma surgery department of a state hospital has developed a hybrid electronic medical record, and it has 9 years of data. And this has been a valuable source of data on trauma patients as well as surgical patients. So the aim of our collaboration was to introduce the concepts of contemporary use of clinical data, as well as to answer questions around quality improvements for trauma patients as well as for surgical patients. So starting in January of 2018, we've had students and faculty from both the US and from South Africa meet and discuss possible topics for research, plan workshops for undergraduate nurses and postgraduate nurses really around using clinical data to improve patient care. And then we have visiting groups of the Doctor of Nursing practice from the US who then come and work with the registry. And we've had 3 such groups since 2018. So the idea is that these Doctor of Nursing practice students come into South Africa and work with the registry and have a look at where the registry is based. They then work with the data and identify potential quality improvement initiatives. And then postgraduate students from South Africa then initiate quality improvement projects in order to address these identified areas. And we've had one publication and 2 additional publications in the pipeline. But what's been really important is also learning about international and interdisciplinary collaboration. There's also been opportunity for staff exchange and also for further project expansion. I think it's really critical for nurses to be involved in practice-based research. And we really need this in order to ensure that the research is able to respond to different capacity needs. And nurses especially are at sort of ground level at the patient and system involvement. And that means that they are really in the perfect position to identify problems, solve problems in the clinical area. There are, however, a number of limiting factors for nurses regarding their involvement in research. Often it's around scarce resources, lack of funding, etc. I just have this slide here just to highlight the fact that I think that we need to be aware of the importance of developing a practice scholar, a scholar who has advanced clinical practice and is involved in the knowledge sort of application as opposed to the knowledge generation of a research scholar. And this is an essential area for nursing to develop in Africa. So just in conclusion, there are many educational aspects to consider along this trajectory. And I think we need to really ensure that we have a responsive curriculum and we'll be able to address these challenges. Responsive research is also needed, and we need to be reacting positively and quickly to these needs. I think it's acutely evident that African nurses are really innovative and resilient, and we need to ensure that there is more sort of interprofessional collaboration, because that is mutually beneficial to all of us. Thank you very much for your time.
Thank you, Petra. Thank you, Petra, for a fabulous talk highlighting the role of nursing in Africa. Anyone who has questions, please put them in the Q&A box. So in the interest of time, we'll move to Deborah Von Zinkernagel. It's my honor to introduce her as the co-director of STRIPE, which everybody here knows about. She's been a leader in global public health for over 20 years, bringing technical and policy expertise experience to many initiatives, and she's a stakeholder to strengthen systems of healthcare with the focus on planning and delivery of health and work with governments in Africa and other areas in the world. Prior to being at UCS, she served as the principal deputy AIDS coordinator for PEPFAR, and she was instrumental in developing the MEPI and NEPI initiatives. She's a strong proponent of advancing skilled health workforce and has served in clinical training and mentorship roles. And she, as a nurse specialist, also has master's degrees in community health, health policy management, and fellowships in epidemiology and research and clinical effectiveness. Thank you for participating. Deborah, and over to you.
Thank you, Quentin. Let's see if I can work to share my screen here. There we go. And we go to a slideshow. See if I can make this work.
There we go.
There we
There
go.
we go.
Yeah, I'd like to thank you very much. I'd like to thank AFREhealth for the opportunity to present the STRIPE, the work activities of STRIPE, which is a partnership of the University of California, San Francisco with AFREhealth, with the support of the Health Resources and Service Administration and PEPFAR. We are nearing the end of 2 very full days of content and rich experience. So thank you for being with us today. So before we start, I do want to add my voice too in recognizing the contributions of Professor James Hakim and Professor David Olai, whose loss we are feeling quite greatly. They've been leaders in this field since the early days of MEPI and leading as PIs of their institutions and wise advisors to us all. So we are grateful for their leadership and their example, and have much work to do to fill what they have encouraged us to do. This is just a quick maybe outline of what I hope to cover today, starting with a short overview of where we started at the beginning of STRIPE and where the program has come today, with a focus, I think, on the work of the year to the second year, ending with some thoughts around what we can explore together for the future. For some of you, this will be a very familiar slide with information that you've heard before. The overarching goal of STRIPE is to strengthen the pre-service training institutions to produce the next generation of healthcare workers that deliver high quality team-based care. In brief, the three guiding pillars of STRIPE's work reflect a commitment to advancing the quality of HIV care through interprofessional high quality education, supporting final year pre-service students with practical case-based training as they prepare for the transition to apply their learning as a working health professional, and to support those early career health professionals with training and opportunities for mentorship that as they address the challenges that emerge in patient care, and also promoting the model and practice of team-based care to improve health outcomes. In line with these goals, the next target population is, as we've mentioned, the next generation of healthcare professionals, both pre-service and those working in the field. The aim is really to bring together an interprofessional group, medical nursing students, along with those studying pharmacy, lab scientists, and other disciplines, and to foster this mix of cadres for training opportunities, so they're practicing in their health facilities. Many of those who are engaged in the STRIPE trainings are studying or practicing in urban and rural areas with diverse populations, and many don't have the support as questions on clinical management arise or addressing other concerns in the workplace. However, they all have an important role and opportunity to have a transformative and impactful presence on the healthcare and HIV response. So this graphic just captures the trajectory quickly that STRIPE has been on, starting with the curriculum development by an expert group of African academics with UCSF support, and inviting proposals from a number of the MEPI and NEPI schools. The first year implementation of training began with the training of trainers for facilitators on the use of the modules to be developed, and then rolling out trainings across 20 STRIPE partner schools and their affiliated schools and facilities. The emergence of COVID, of course, stimulated the need to offer additional training resources and materials, and to adapt and make these materials available in online and digital technologies. So supplemental funds were used by 4 schools to develop and test out a number of e-learning strategies for HIV training resources, and also those on COVID now added. In our year 2, we focused on developing and rolling out a learning management system, which you'll hear about, hosted at AFREhealth, and providing online workshops and independent self-paced learning opportunities for partners. Not included in this slide, though, is an additional component of work, the James Hakim Leadership Development Program, which merits another whole separate presentation in itself. This program is a partnership of AFREhealth and UCSF, and is providing a 12-week training program for mid-career and emerging leaders, and includes a component of individual mentorship. If you'd like to learn more about this, please contact the AFREhealth Secretariat, and they can give you additional information. Here. So with the impact of COVID, both on the educational support, which is greatly disrupted, and the impact on the health systems and the health professionals delivering care, it just cannot be overstated as well. You're familiar with many schools having to close their classrooms and no longer able to convene the in-person workshops. There was a need to adapt and transition to the online training tools, using both virtual workshops to combine interactive Zoom sessions with self-study, and also to make independent self-paced learning modules available through the learning management system. So new demands placed on the frontline providers also called for new content to be developed, including infection control and prevention, testing, diagnosis and triage, management of care, principles of containment and mitigation. The opportunity for AFREhealth to extend webinars on COVID-related matters across the broad network that it has, and growing capacities at the AFREhealth Secretariat, really advanced the goal of increasing AFREhealth's role in running the program activities of STRIPE. Both the challenges of putting the technical platforms in place and developing and tailoring the resources to be delivered through a learning management system has been a large task and accomplished in a very compressed time frame. A new partnership between UCSF, UKZN, and AFREhealth was put in place to set up a server and to build the platform for the LMS. And the LMS was then piloted by 3 schools that had experience in delivering online learning, along with exploring some other digital technologies that could be useful, Google Classrooms, Vula, etc. So a survey of the Stripe partner schools was done to identify what platforms would be most suitable to them. And Moodle was the one that the most were familiar with. Zoom was also favored and was being used by some institutions to deliver lectures and conduct classes. So a hybrid model has been pursued to accommodate these different needs and preferences, with the option of a self-paced independent learning materials online and virtual workshops that incorporated interactive Zoom sessions to discuss materials and short exercises that were included in the online materials, but really did help to foster that opportunity for discussion and interprofessional exchange. So issues of availability and consistency of the internet access and the cost of data were often factors in what modalities partner schools chose to pursue. And many of them are offering a combination of the two to reach different groups of learners. So the Stripe materials have now been adapted for use on the LMS, both for the self-paced learning and more easily accessible to people who are very busy and have limited time to give, and those adapted to with storyboarding kind of pictures and a lot of graphics and interactive features included in them, as well as those designed for including activities that can be conducted in small groups using the Zoom sessions in between and at the beginning and end. So throughout the process, all the materials were reviewed by an interprofessional team to embed both the experiences of interprofessional team-based care throughout the modules, both in how they were developed and how we shared them. So 9 training webinars were held. And the next step of as part of introducing the webinar, it was important to get the faculty and facilitators familiar with both using these and how to engage and sustain learner interest. Excuse me. Fostering an interprofessional dialogue with people spread out in remote settings where you don't have that person-to-person contact isn't easy. So I think opportunities to work with and try different strategies, icebreakers, things that help to keep a group together, I think were important to offer and to share. So AFREhealth led 9 training webinars to increase facilitators with the use of Zoom and also the LMS. Each school then identified an e-learning coordinator and they selected facilitators to participate who will be leading trainings at their institutions. 175 facilitators were trained on the Zoom, and 151 became familiar with the use of the Moodle-based platform. This is just a very quick snapshot of a training that was held for facilitators. A valuable part of this has been building a community of practice among the e-learning coordinators. They chose to put a WhatsApp group together to exchange experiences, to help with troubleshooting and with ready access to both the AFREhealth and UCSF support. Year 2 has also seen an expansion to new additional partners and government clinics and slides. This is a very busy slide, but it gives you a flavor of the distribution of the institutions that are leading in this work. Online training opportunities to bring these trainings to new audiences, including those in distant places and busy working people, I think has really been a benefit of having the online materials. So Stripe now includes 23 universities, along with 79 affiliated partners. And these now include more Lusophone and Francophone sites, training sites, which we're really delighted about. The modules have been translated into French and Portuguese, with the vision of being able to expand Stripe resources more broadly in the future. Stripe is also now expanded through a new mechanism of vendor contracts to include 8 new schools focused on training nurses and midwives. Judy Khanyola, who's a moderator for this session, has been the coordinator for this new expansion, and it's very rewarding to bring more schools of nursing into the Stripe network. These are the future professionals who are often the frontline providers of care. 3 schools are in Lesotho or under the umbrella of the Christian Health Association of Lesotho, the Maluti, Pare, and Roma schools, and another school, the National Health Training Institute, which is formally affiliated with the Department of Health, National Department of Health. 2 schools are in the DRC, the ISTM Kintambo and ISTM Immaculée Conception, and 1 is in Ethiopia at the Arba-Minch College of Health Sciences. With the transition to Stripe Online and Individual Learning still very much in the early stages of being brought to scale, it's been heartening to see what Stripe partner institutions have been able to accomplish in a very short few months. Between May 7th and the 29th of July, there were 2,897 registered learners for the virtual workshop course and 1,109 registered learners for the online course. Additional learners are now being reached by the vendor contract schools, with 491 registered learners and 164 having engaged in training. These AFREhealth schools just began these activities early in July, and we know they're excited and are ramping up their work. With the drive of PEPFAR really to improve health outcomes, Stripe has been working to collect data from year 2 on where the learners are being drawn from and where they're working. So our data collection is still early on this, but it shows that learners have been drawn from 495 PEPFAR facilities or regions, and these are registered on the LMS and participating in trainings. One innovation piloted in Uganda is a partnership of Makerere University with the Ministry of Health and PEPFAR to identify facilities where health outcomes for HIV care were less favorable. So this has allowed a focused effort to offer training to healthcare professionals who are serving there. So the experiences of moving to online and virtual training has offered new opportunities, obviously, to expand the reach of educational offerings, but it's also highlighted challenges along the way. Some advances have included continuing to offer training opportunities with no need for travel or in-person gatherings. E-learning can be made easier to scale up trainings more widely, reach new partners, and make these available in off hours when people have the time where they live and work to take them. The self-paced learning, I think, is a very helpful addition in that where it's very accommodating to what people are able to do. And AFREhealth has built, the LMS has built, I think, a very unique platform for AFREhealth to build on, potentially expand to other diseases and conditions that are prevalent in the population. But change is hard, especially in the middle of a pandemic with constraints both on students and busy providers dealing with multiple work and life issues concurrently. Limited bandwidth and consistent access to internet is always an issue, and the cost of data has served as a challenge that had to be addressed. For some, the availability of computers and iPhones are either limited or absent. There we go. So as we look ahead, I think the opportunities to further expand training opportunities to more sites is certainly top of mind. And also the considerations of expanding clinical domains through materials that can be developed and made available through AFREhealth on the LMS. And there's the opportunity for AFREhealth to expand to more partner institutions, something I think is definitely on their mind to consider, and I hope that will be very much possible. So my last slide is an announcement of a new opportunity that UCSF and AFREhealth are collaborating to make available. To date, the learning materials and trainings have really been offered through straight partner schools and institutions. We want to open that opportunity up to familiarize others who might be interested in these by introducing a Stripe Global Workshop during the weeks of August 23rd to September the 3rd. There will be 4 modules listed here that will be made available and worked through in that time. The first week will be dedicated to independent learning, independent time to work through the materials of the 4 modules, with the second week being a time to conduct interactive Zoom sessions for each module that you discuss the exercises, the reflections, things that are incorporated in the virtual workshop materials. We're still assessing what the level of interest may be for this, and at some point we may need to cap the numbers if it gets too large, and possibly to repeat this in the future if there's a lot of demand for it. And lastly, I want to acknowledge the work of many people who have contributed to the work of STRIPE, and especially in this second year, including AFREhealth and the UCSF instructional designers and the technical teams, and the AFREhealth management team, without whom none of this would have been possible. And major appreciation to all of the STRIPE partner schools and universities who've carried out this work. I'd like to acknowledge again the funding support of Health Resources and Service Administration and the PEPFAR. And thanks very much for your kind attention.
Thank you, Deborah, for a fabulous talk and summarizing that incredible initiative. I think in the interest of time, I'll go straight to Dr. Alex Coutinho, mispronouncing his name, but his CV is too extensive. We tried to practice it before, but I didn't get it right. There's an extensive CV, which will take 15 minutes to get through, so I'll just give some highlights. He's been practiced medicine in Africa for over 33 years, has been the Director of Partners in Health in Rwanda for many years, outgoing chair of the board of the International AIDS Vaccine Initiative. He's done a lot of work with the Ministry of Health in Rwanda in areas of oncology, neonatology, mental health, and NCDs, on the interim board of the Global Fund, and he served as chair of the TRP and chair of the board of the International Partnerships on Microbiocides in 2013. And he was awarded the very prestigious Hideo Noguchi Africa Prize together with Dr. Peter Pyatt. Fabulous. So it's an echo. So over to you, Dr. Coutinho.
Thank you very much. And let me start my slide. Good evening, good afternoon, and good morning, depending where you are. Today, I'm going to be talking about the translation of HIV research and science on HIV service delivery. And no, excuse me, this is the different, just 1 second. I have 2 slide desks that have, where did we go now? Yes, there we go. So I'm going to be talking about how do we translate HIV research and science on service delivery and see what has really worked, particularly on the front line in Africa. Let me get my slideshow working. There we go. So we need to remember where we are coming from when we're talking about the impact of research. And for Africa particularly, the heartbreak years were between 1982 and 2002. You know, there's 20 years. I first saw my first case of HIV actually in 1982. Even at that point, I wasn't aware that we were looking at a disease that was going to define my medical career. And as harrowing as these photographs are, they're important to look at because they remind us how much HIV research has contributed to where we are today. And indeed, soon after 2002, with the establishment of the Global Fund and PEPFAR in particular, and the availability of antiretroviral therapy globally, there were major impacts and improvements. And this photograph shows clearly, you know, I'm living proof that ART works. And I will be touching on this on some of the key research that has led to a change in the landscape of HIV, particularly here in Africa. And this really summarizes the impact of many pieces of research, stopping here in 2018 from when the data I could find is available. And the blue line, of course, is showing new HIV infections, which peaked around 1998, and then have been on a decline, although not as steep as we would have wanted. And similarly, the red line is showing the numbers of death as a result of HIV, reducing markedly soon after the introduction of wide-scale antiretroviral therapy in Africa. But clearly, as you saw from a previous slide of new infections, we're missing the mark, particularly in reducing new HIV infections. The target in 2020 would have been 500,000 people, new infections, but was closer to 2 million. And there are many reasons for that. And I'll be touching on that in terms of some of the research that has not actually been taken up to scale. PMTCT in Uganda is an example of this. PMTCT around the world has been an important success story. But even with the availability of services, with even the scientific proof that PMTCT works, you can see that we've never got to zero, that there's been a decline, but you still have a residual number of HIV child infections, even as pregnant women in blue here are increasingly receiving antiretroviral medicines, that is HIV positive pregnant women achieving a 90% access. And all this is translated in this classic curve that was first published in 2016 that shows how life expectancy in selected countries dipped as a result of the HIV epidemic, and then started recovering from 2002, which is when antiretroviral therapy started being made widely available in Africa. And there's been lots of progress in HIV prevention. This slide captures some of the approaches, and in particular, the introduction of ART treatment as prevention. Up to that point, there was this artificial separation between approaches for HIV prevention and then treatment. And some of the studies that show that treatment is very effective as prevention has helped us to rethink of a more holistic service delivery that merges preventive and treatment approaches. But let me share a personal story. In 1986, in Uganda, my eldest child was born. And at that point, and I had no gray hair, as you can see on the right, I thought an HIV vaccine was 10 years away. Well, recently I was in Cape Town, and my son has his own daughter now. So I'm a grandfather. And there's been lots of progress, but no vaccine yet. So there remains certain research that is really critical in order to take us forward in preventing HIV and also improving service delivery. And I'll be touching on that pretty soon. We need to remember that there's a wide range. When we talk of research, this is a slide that summarizes basic and translational science intersections. And basic science is called a T0, whereas translation community is a T4. There are some very important pieces of research that start out as TO and go all the way to T4. And we'll be talking about a few of those. Some of them just stop here at T1 in terms of proof of concept. Some stop at clinical trials. Some will go on to be incorporated into public practice policy. But very few finally come through to have population outcomes, and I'll be touching on some of those. And some of the key ones I've summarized in this slide, but this research on male circumcision, but I think one of the key ones which I will allude to is this study by Tom Quinn and colleagues in 2011 that looked at the correlation between viral load and HIV transmission, and also the study on male circumcision and risk of transmission, as well as HIV and other sexually transmitted infections in a cohort of women. But it's not just about science, because even if you do have the science, you have to bridge politics and you have to learn about implementation science and all the opportunities and pitfalls that you face. I used this slide at CROI some time back, and sometimes you have messaging that is coming from On the left side, sometimes donors and well-meaning partners who ask questions like, you know you're HIV positive yet, you don't want to start on ART, why is proven science not being scaled up rapidly? You know about risky sex, but you don't use condoms or PrEP. If you don't understand science, why do you keep challenging it? And on the other side, the communities are saying, your interventions will just make our children have premarital sex. Why is the West obsessed with key populations, and so on and so forth? And you know, if you really want to look at population impact, as much as you need T4 research, you also need a whole set of other intersections, which I'm summarizing here. And because of time, I can't go into each of these boxes and unpackage them. I'm happy to share my full sets of slides that I shared in CROI that go into some of these things that have to work together. So HIV science and research on its own is not going to necessarily make a huge difference unless all of these are interconnected. And an example of this is that some of the science and some of the research will translate into population impact. On the left, the science around treatment with support, particularly from funding from the Global Fund and PEPFAR and in-country funding, has taken us towards the target of the numbers of people who should be on treatment, whereas the science of PrEP is just as solid, but we're seeing far fewer figures of individuals who are actually on PrEP. So, which are my top? And when I say mine, I don't mean Alex Coutinho. I actually consulted 6 colleagues who I have great respect for in the research that they have carried out in Africa, as well as translating some of this research into large programs, both in TASO, in IDI, and in Partners in Health, which are organizations that I helped lead at some point in my career. And they gave me and myself, we agreed on 6 top scientific discoveries. The first is the characterization of the HIV virus and its mode of transmission that allowed at the time, before antiretroviral therapy in particular, the application of standard STI protocols, particularly abstinence, be faithful, and condoms, at a general population level, despite full protection of these measures. But at that point, we didn't have much else, and we couldn't have done that without understanding modes of transmission in particular. The second was discovery of HIV testing, especially point-of-care HIV testing, that allows the identification of people's HIV status and improves access to care and treatment, as well as reinforces prevention and identifies discordancy. This now includes self-driven testing like OraQuick that you can do in your own home. The third is research around the linkage of viral load and transmissibility of HIV that enabled the concepts of treatment as prevention and U equals U, undetectable equals untransmittable. And that is the research that was done by Tom Quinn and colleagues and published in 2011. The fourth, of course, is the discovery of antiretroviral therapy, the move from monotherapy to combination therapy, as well as progressive research in this field that improves the quality of life of people living with HIV and AIDS with reduced pill burden, better safety profiles, reduced adverse events, and greater efficacy at suppressing viral load. The fifth is the discovery of the efficacy of antiretrovirals in PMTCT protocols that resulted in reducing markedly the transmission of HIV to infants and children, as I showed in the slide before in Uganda. And finally, it was very difficult, not to keep going till 10, but finally we stopped at 6 and said improved and simplified clinical protocols that have allowed service delivery to be decentralized, task shifted, and often community-based. And this has in particular enabled massive scale-up of treatment, particularly driven by nurses and midwives. We also listed 5 discoveries that have not resulted in major impact on service delivery. The first is some prevention approaches that have full scientific evidence, but have not fully translated into uptake at population level in several countries, like voluntary medical male circumcision and PrEP. Secondly is INH prophylaxis to prevent TB reactivation in HIV positive, as well as the prevention of advanced HIV diseases like cryptococcal meningitis by using drugs like fluconazole. The third has been translation or failure of translation of what works scientifically into vulnerable populations like adolescent girls and young women, men who have sex with men, commercial sex workers, prison populations, MMM, and intravenous drug use. And in case you don't know what MMM is, that's mobile men with money. And the fourth is interventions to address drivers of HIV like poverty, social cultural practices, and lack of female education in particular. And finally, despite great scientific knowledge, the optimization of pediatric care for HIV positive children. And as I come to an end, I also wanted to point out new horizons, areas of research that could improve service delivery in the future. These include new point of care testing for HIV viral load and diagnosis of TB in particular, the drive for an HIV cure, in particular identifying HIV reservoirs and approaches to eliminating the virus in these reservoirs, long-acting ARVs for both prevention and treatment that would reduce the need to utilize health services. This is just around the corner. And then targeted socioeconomic cultural approaches that reduce risk and vulnerability. And the last one is destigmatization and criminalization of key populations to enable better access to services. So these are the new horizons. If we don't do these, then service delivery will both not be optimal and definitely not be equitable. So I'll zoom through in my last minute, just pictures of my teams. I'm very proud of these teams that scaled up sometimes from 0 to 100,000. Bottom left, for instance, is voluntary medical male circumcision. When we started in IDI, out of 1,000 staff, I was the only one that had ever circumcised anyone. And from myself doing a TOT, the teams managed to circumcise 100,000 people in 1 year. And these are teams doing voluntary counseling and testing near the Congo with border. This is on Lake Victoria. And these are other activities that really were able to be scaled up following some of the research. I want to acknowledge the experts who gave me feedback, Professor David Serwada, Dr. Gaudensia Mutua, Dr. Joanita Chigozi, Dr. Andrew Kambugu, Dr. Alex Muganzi, and Dr. Andrew Mujugira, who enabled me to come up with this prioritization. Thank you very much indeed.
Thank you so much, Dr. Coutinho. This is an incredible trajectory of your career that you put before us, and greatly appreciate it. I think, Judy, we have time for 1 or 2 questions, right? So,
yes, we do.
Okay, so there are 2 people, this can be answered quickly, want to know if there are any doctoral programs for nursing. And then Dr. Ian Cooper asks, and I think this is probably directed at Petra, something that AI and machines cannot provide is compassion, connection, and care. The human touch for which the hand of God is a poor substitute. Medicine and nursing share the problem that many people and patients, clients, and communities feel that we have lost care attribute of healthcare. How do we address this non-technical component in our education going forward? So 2 questions. Petra, I don't know if you want to address both of them. Doctoral programs.
Yeah, the first one is I presume is about Doctor of Nursing practice, which is different from a PhD. Yeah.
I see.
So to my knowledge, we do not have any Doctor of Nursing practice programs in Africa. And I think we have to ask ourselves whether it's something that we do want. I think it's a thing that the nursing profession needs to discuss throughout Africa. So no, there's no Doctor of Nursing practice programs in Africa. And I see Judy's agreeing with me. And then the second question is that I completely agree with Ian, that you cannot replace the human touch. And I see he didn't like my hand of God. But remember, that hand of God is only there because there is no person to hold hands with our social isolation and our limited staff. So I completely agree with him. There's nothing to replace the human touch, but robots, AI, it's coming. And I think we have to be the ones that can suggest how is the best way for that to be incorporated into nursing, because we don't want to lose the caring and compassion. I completely agree.
Thank you.
That's my answer. And I would be looking to people like Ian to be helping us on this road too.
All right, I think we run out of time. Judy, did you want to make concluding remarks?
Thank you so much, Quentin. Thank you for a very scintillating session. It was really excellent, and I wish we had 15 more minutes, for example, to delve deeper in what Dr. Alex has presented around translating the research into actual, almost moving to what Petra is saying, touching a patient. And I just want to say that we cannot separate the medical and nursing education and research from the actual human beings, the people that we are meant to give hope, to give succor, to give help and support. And thank you to the three presenters, Deborah, for your wonderful analysis of the STRIPE work, Petra, for the great work you're doing around the translation some of these new technologies, and Dr. Alex, of course, for your wonderful trajectory in Africa. I've kind of followed your career a little bit. I interfaced with you at some point in mine, and I really do admire the work that you have done and continue to do. Colleagues, we have to move to our final plenary, so I will bring this session to an end, and thank you so much to all of you. I believe the recordings will be available to you through the Secretariat, so please go to the website to access all the recordings from our plenary this afternoon. Thank you, and all the best.
Bye.
Thank you very much.
Bye. Bye. Thanks again, everyone.
Thank you, everybody.
Thank you very much. So Abigail, our president, will take up from there.
Good evening, good morning, good afternoon from all over. This evening we are closing. This has been a fruitful two-day symposium meeting, and we have 3 activities to do within this shortest period of time. The first activity is to recognize our past president, and then we'll also launch a book for AFREhealth, and finally the executive director.
Please go ahead and we'll share the screen. Yes.
Thank you so much. The first awardee is Professor Peter Donko. He was the first president for AFREhealth from 2016 to 2018. AFREhealth recognizes Professor Peter Donko as the first president of this esteemed organization. You served AFREhealth from 2016 to 2018. During this time, you led the forum in developing governance instruments and structures. These developments were made possible with minimal funding from Health Resources and Services Administration through the Health Workforce for the 21st Century Project. You mobilized a team that developed the first unique and competitive National Institute of Health grant, specifically tailored to set up AFREhealth. Under your leadership, AFREhealth received the first NIH funding that is supporting the establishment of the forum. You carried out this task over and above your busy schedule as a maxillofacial surgeon in Ghana. Your dedication and enthusiasm to the work of AFREhealth is highly appreciated. We recognize your hard work and diligent effort to start AFREhealth as a new organization and turning it into a stable body. Thank you for your exceptional performance. Professor Peter Donko. Is he in?
Yes, please. His video is on.
Okay.
Yes.
Okay. We just wanted to flash him.
Hi, Abigail. Thank you very much. I feel highly honored, and it's wonderful to see that things are going so well. I'm very sorry I haven't been able to join you so far. Just been distracted elsewhere, but I'm happy that AFREhealth is alive and kicking. It's a real honor and privilege for me to have been a part of this birth. Thank you very much for this honor. Thank you.
You're welcome. The next awardee is Professor Marike Tiberius, second president of AFREhealth from 2018 to 2020. AFREhealth recognizes Professor Marike Tiberius as the second president of this esteemed organization. You served AFREhealth from 2018 to 2020. AFREhealth experienced rapid growth during your tenure. The Secretariat was established to almost full capacity. For the most part, you acted as Executive Director. You led the development of up to 20 policies that are key to the operations of the forum. The Secretariat now has the capacity to receive and manage grants. You successfully led the implementation of the first grant on interprofessional education, strengthening interprofessional education for HIV care. As a family physician, you implemented AFREhealth agenda, adding to your busy schedule. With the coming of COVID-19, you guided AFREhealth to a new direction to train health workers using online platforms. We congratulate you on your unparalleled work on building AFREhealth into a highly productive organization. Your proactive approach of ensuring that the organization grows is treasured. It was a privilege to have had you at the helm of our leadership. Thank you so much, Marike.
Thank you so much. Thank you so much, Abigail, Georgina, and the team. I'm really humbled by this award today, which I don't deserve as a person because it was a team effort all the way. And I was really privileged to work with so many people across Africa and with our northern partners to make this possible. And the best reward for me is the last 3 days, where, as Peter said, where we see how far AFREhealth has come. And having seen that, I would like to say or predict that it will go even much further. Thank you so much, everybody. It's a real honor.
Thank you so much, Marike, for that. We appreciate all of you. I'll move on to the next activity. As I indicated in my opening speech, AFREhealth has come up with a book and would like to launch this book now. The title of the book is Transforming the Medical Nursing Education Partnership Initiative into the African Forum for Research and Education in Health, the Journey So Far. Background, sorry. Okay. The background is as follows. AFREhealth is an independent body that emerged from the NEPI, and it was funded by PEPFAR and NIH and awarded to selected African medical and nursing schools. The idea of a book evolved as a means to document the journey so far as we begin to reflect on the aspirations of the future. The justification for the book is that envisaged that AFREhealth will contribute to implement its activities in sub-Saharan Africa efficiently and effectively, and also to chronicle the journey so far for the new generation and look forward by brainstorming on foreseeable AFREhealth's focus and agenda to define it all for accelerated health improvements and positive outcomes on the continent. And the last justification was that this historical perspective will be able to answer vital questions, including where are we coming from, where are we now, and where are we heading as a community. This book represents a call to all who have passed through the transformation journey from NEPI to AFREhealth, as well as the observers from the AFREhealth community, including AFREhealth partners and students. The process, I'll quickly summarize. We have included all members across the linguistic regions, and we also invited a mixture of other experienced and young members to participate in the book writing, as well as those with experience in publishing. And there are 5 themes. One is about AFREhealth itself, where we give the background, the historical perspective, and the need for an Africa-wide network and its transformation. And then the other one is on research. We look at the past, ongoing, or future research work in selected areas. And the third is it looks at political flavor and it gives overview of politics and its relevance to organizations. And then AFREhealth community in general, where we are reaching out to networks and partnerships. And finally, the next decade of AFREhealth and the way forward cuts across various chapters and from the students' voices across Africa as health's next generation. The book has 9 chapters. The first chapter, I'll just summarize this. The first chapter is about historical perspective, the past, present, and the future of AFREhealth. Chapter 2 is strengthening the development of the AFREhealth Secretariat from 2017 to 2020. Chapter 3, leveraging the AFREhealth network for COVID-19 research, collaboration, achievements, lessons learned, challenges, and the way forward. Chapter 4, overview of the AFREhealth Student Advisory Committee. Chapter 5 is about research on health professions education in sub-Saharan Africa. And chapter 6, highlights of the past, ongoing, and future research work, where we look at perspectives on TB, malaria, and NCDs and other diseases. Chapter 7, the politics in and of AFREhealth. Chapter 8 is about AFREhealth and its collaborative partnerships towards improving health, education, and research in Africa. And finally, chapter 9 is about African student voices. The book has been translated in the languages, Portuguese, French, and English, and soon when we penetrate through the Arab phone, we'll also do the same so that everybody within the continent can access it. In conclusion, I'll summarize that too. The book promises to engage all members in the AFREhealth community, including executive committee, governing council, other interested or solicited members, and others. The book is timely and essential for the present generation to brainstorm and utilize as a reference point as we advance the course of the organization. It also captures a different audience and can be of interest to scholars and funders, and the print will be for these parties and will be distributed to other AFREhealth networks to further enhance advocacy, awareness creation, and promote inclusiveness. The book is free. And finally, I would like to acknowledge the many people that helped us with this book. We are grateful for the NIH, Faculty International Center, for the grant that supported publishing this book. We are indebted to the authors whose contributions has provided the foundations from which this book has evolved. A special thank you to the AFREhealth Secretariat staff, especially the Executive Director, Mrs. Georgina Yeboah, Senior Program Manager, Mr. Irenaeus Dazoberi, and the Senior Administrative Human Resource Officer, Mrs. Clara Samwood, for their active involvement in the book project, especially interfacing between the authors and the editor. Finally, we would like to thank the Governing Council, Executive Committee, and the NIH grant for approval at different levels to embark on this book project, as well as the IDI team that have supported the process as the NIH grant managers. Thank you so much. I now declare the book launched. I now pass on to Georgina to close the symposium.
Thank you very much, Abigail, for the honor that has been done to our past presidents for the good work that they have done for this wonderful organization. And thank you also for the book launch. And with the book, we are also grateful to the editor, Presta, for the sleepless nights that she has to do for the editing. colleagues and friends. Finally, the announcement of save the date, register for the symposium, everything today has come to an end. And we are seeing this reality and this success because of all of us. And so I want to express our appreciation on behalf of the Governing Council of AFREhealth, first to our funders, NIH. They did not only fund us, but they also participated throughout the sessions of this symposium. They were with us at the GC meeting, at the AGM, and throughout, and we are very grateful to them. Our partners, IDI, UCSF, DPIGO, Sanford, University, Gardner, all the other partners, we are very grateful to you and our emerging partners. Doctors Eric Goosby and Roger Glass, the goodwill messages, we are grateful and they have motivated us to get this far. Our wonderful plenary speakers, we are grateful to you also for really engaging us with all the thought-provoking presentations. Our moderators, you were wonderful, ensuring we kept time, taking our questions and ensuring they were also addressed. Abstracts and poster presenters. If you hadn't brought your abstracts and posters, we wouldn't have seen what we've seen today. We really enjoyed them and the discussions, and we are grateful to you. To our members and to participants, if you have not registered to participate in this program, we wouldn't have seen it becoming a reality and success, and so we are very grateful to you. Hard-working steering committee members, secretariats, our IT moderators, we are very, very grateful to all of you. We didn't know we would get this far, but you've really worked hard and we are so grateful to you. I wish to see this opportunity to encourage all those who are not members of AFREhealth to join us as we advance interprofessional excellence in health professions, education, research, and service for Africa. Please go to our website, www.afrehealth.org, the membership portal, and complete the membership form, and also ensure that you are in good standing by paying your dues so that we can all move this our great institution forward. Next year, 2022, we are hopeful that we shall all meet again in person in Zimbabwe for the 2022 annual symposium. Thank you, everyone. And though we have ended the symposium, tomorrow we have satellite sessions for technical working groups, work of ECFMG FEMA, and the AFREhealth CUGH working group. Please join us. They are for free. Please join us and see the wonderful work that we are doing. We have speakers, and so we want you to join us. Thank you, everyone. And the book, we will make the soft copy available on our website, and then we shall also distribute the hard copies to our various members and various institutions. Thank you, and I wish you well in all your endeavors the rest of the year. Stay safe. Bye-bye to everyone.
Please, let's all stay for a picture.
All right, please, let's have our videos on for all videos on, please.
Picture.
Oh, yes, all videos on. Yes, all videos on. A smile on your faces. Because this is a great feat. And so let's see that.
And
your face.
Judy, that looks so good.
I had these headphones, so I had to remove them. Thank you, everybody. Thanks, Georgina. Thank you all. It was wonderful.
Thank you. Thank you.
I think you will not respond to emails after this, Irenius, to Judy's email.
Thank you all. It was great.
Thank you all.
Bye.
Onunja